The following podcast is part of a certified educational activity titled A Light on the Horizon, Improving Alzheimer's Screening and Diagnosis Through Quality Improvement. Access the entire activity and complete the post-test at peerview.com/PEW860. Downloadable slides and practice aids are also available.
Hi, my name is Dr. James Galvin. I'm professor of neurology at the University of Miami Miller School of Medicine. Welcome to our program, A Light on the Horizon, Improving Alzheimer's Screening and Diagnosis Through Quality Improvement. Our goals for today are to, 1, enhance your understanding of some of the recent advances that have been made in Alzheimer's disease, their diagnostics and treatment, that may help you improve patient outcomes. 2 is to increase your awareness of the opportunities for process and workflow improvements in a health system in order to ensure optimal care for our patients. And 3, to improve your ability to implement quality improvement methods and improve timely and accurate diagnosis and treatment of early symptomatic AD. Our first module will focus on translating advances in Alzheimer's disease research into improved patient care. So, first question is, who should be evaluated for cognitive impairment? Really, any patient you're concerned about. So, if a person self-reports, they say that their memory has changed, or if their loved one, a spouse, a friend, another family member reports something, or if a clinician reports any concerns about symptoms of cognitive, behavioral, or functional decline, those patients should be evaluated. It's really important to ask about cognitive, functional, and behavioral impairment during the annual wellness visit or any visit that cognitive decline may be suspected. Don't dismiss those mild memory complaints. They could be the first sign of a real problem. Use the EHR to flag any potential indicators of cognitive decline. You should consider screening adults for hearing and vision loss before doing a cognitive assessment because that sensory change really could, 1, interfere with effective communication, and 2, could be the cause of their complaints. Always try to capture those family concerns. They're there with the patient. They're seeing the change. It could be a very useful source of information. But there's a recent recommendation from the Alzheimer's Association about how primary care and general specialty care could evaluate patients with cognitive impairment. There are 7 core elements. 1, establish shared goals for the diagnostic process, then do the history of the present symptoms from the patient and, if at all possible, from a care partner. You want to do a systematic, structural, multi-domain review. Look at their cognition, their activities of daily living, behavior changes, and their sensory motor functioning. Look at the biopsychosocial history and all of their risk factors. So from development, social history, family history, their health-related behaviors, all these things are going to be helpful. You want to do a complete both physical exam and a neurologic exam. You want to integrate all of this information so you can begin to formulate the diagnosis, and then you want to disclose that diagnosis to the patient and the care partner. That's important for developing a shared care plan. Now, let's switch to biomarkers because that's really an exciting emerging field. Last year, there was a revision to the recommended sort of biomarker characteristics and categories for making a diagnosis and staging. We're really moving toward what looks like what it was developed for cancer with Alzheimer's disease. So we have these core 1 biomarkers, and they focus on the amyloid pathology. So you can look at amyloid itself, for example, in plasma or in CSF by looking at that A-beta 42/40 ratio. You can do amyloid PET imaging. You can also look at phosphorylated tau, which more closely reflects amyloid pathology. And this is mostly looking at the levels of p-tau 217. There are other p-tau assays available, but 217 is probably overall the best. The gold standard still remains imaging by the amyloid PET scan. The core 2 biomarkers are now looking at the tauopathy, the actual tau pathology, and there are several markers available in CSF. To a lesser extent, they're available in plasma at this point. And then by imaging, there's a tau PET. So doing those first 2 allow you to establish whether there's an amyloidopathy and a tauopathy. And then there are other biomarkers looking at neuronal injury, inflammation, vascular pathology, and synuclein. I encourage you to look at the references included at the bottom of these slides for more information. So when is biomarker testing right for your patient? It's really indicated for those people that you have an objective evidence of cognitive impairment, and you're going to do a diagnostic workup for the potential of initiating a treatment, okay? We're really not looking at people who are not cognitively impaired at this time with these biomarkers. It's not the appropriate use of them. So the biomarker testing will tell us whether AD is a likely cause and that it could be affected by the diagnosis and or management of AD. Now, there are a number of clinically available biomarkers, and I'll go through each of these categories. First, PET scan. A person is injected with a radiotracer that binds to amyloid plaques. The PET scan then allows us to visualize these changes. It's visually read as positive or negative. Now, some centers can provide continuous values. These are called centiloids, but predominantly in the community, it's going to be read as positive or negative. Now, there are a lot of advantages of this. It helps you visualize the burden and the distribution of plaques. It's FDA approved and covered by Medicare. It's considered a gold standard. There are some downsides. It requires expensive, specialized equipment with highly trained personnel. It's not available everywhere. Now, Medicare covers it, but commercial insurance plans may not, and it does require radioactivity. So it is the gold standard, but it has some challenges associated with it. What about CSF biomarkers? Well, this requires a person to undergo a lumbar puncture to collect the CSF. And not everybody is willing to do a lumbar puncture, but with a single tap, you can collect fluid that allows you to measure a number of markers all at the same time. So you can look at amyloid, you can look at tau, you could look at both phosphorylated tau and total tau. So it actually gives a lot of information. We understand the ranges, so there are positive, negative, or intermediate or indeterminate levels that are found in fluids. You can get a cutoff ratio so that you can understand whether people are above or below those ratios. So advantages, you can test for non-Alzheimer conditions. So you can look for primary tauopathies. You can also look for other biomarkers that we're not covering here to look for other conditions. It is FDA approved. It's covered by nearly all insurance. And you can measure concurrent genotype testing. But disadvantages, most patients are not so fond of LPs. They don't really want to do it. They perceive a lot of risks. There are some contraindications, and it is time consuming. It takes up a lot of time for clinician and staff time. And so it's not always done. What's really exciting is the emergence of blood-based biomarkers. Here, it's simply a blood draw. You can measure the concentrations of numerous proteins at the same time, including A-beta 42 and 40 and p-tau217. Again, interpretation of the test, positive, negative, or intermediate based on established cutoff values. A number of advantages. It's more acceptable, it's readily accessible, it's less burden, and less expensive. Okay. In May of this year, the first blood-based biomarker received FDA approval clearance as an in vitro diagnostic. Now, disadvantages, it's not yet reimbursed by Medicare or other insurance plans, and so you always want to check with your patient's insurance and see whether they'll be covered. Sometimes it is, sometimes it isn't. It's hard to know a priori. There's variability in the accuracy of the different blood tests, and I'll go through some of the ones that are available in a bit. Some of the tests may not perform the same in all groups, particularly if they have certain conditions like chronic kidney disease. And the current test may not reflect amyloid clearance on an individual level. So while the PET scans and CSF markers are used sometimes to look at response to therapies, it's not so clear whether all of the blood-based biomarkers can do this. Now, as I mentioned, the FDA cleared the first blood test as an in vitro diagnostic, and that is the Lumipulse G p-tau217 beta-amyloid 1:42 ratio. This is good for the early detection of amyloid plaques associated with Alzheimer's disease. It's the first cleared. It's not intended as a screening test in asymptomatic individuals. Remember, this is for people you identified as being symptomatic. They have an objective finding. But in a large study, it had excellent positive and negative predictive values. There sometimes is an indeterminate result that occurs in about 20% of patients that does require confirmation testing, either by PET scan or by CSF studies. Briefly, these are the clinically available p-tau217 tests in the U.S. As a blood test, the p-tau217 is the best single marker. If you can get a ratio, that's better. But the p-tau217, if it's the only one available, is the best marker. A beta alone in the blood is not as valuable. All right, let's move on to disease-modifying therapies. Now, it's important to know that the antibodies that are currently being used and have been investigated for treating Alzheimer's disease are really all targeting different species of amyloid. So the two approved medications, lecanemab, binds to protofibrils, while donanemab binds to plaques. So they are addressing different parts of that amyloid cascade. Medications that have not received approval or are no longer available targeted different areas of this cascade. And they differ in their preferential selectivity for the different species. This may translate into differences that we see both in efficacy signal as well as safety signals. So that's important to remember. The basics of using amyloid-targeting therapies. They're the first disease-modifying medications approved for the treatment of early-stage Alzheimer's. That's either MCI due to Alzheimer's or mild dementia due to Alzheimer's. They can lower amyloid plaques substantially. Many patients will become amyloid negative in 12 to 18 months. The evidence shows a slowing of clinical decline by 20 to 40%, depending on the measure you're looking at on the average patient, when the amyloid plaques are lowered. These treatments can provide, on average, about a 5 to 7 month savings compared to placebo. There are risks. I'm going to go through those. There are infusion reactions, which occur in some patients, particularly in the first 1 or 2 infusions. And then there are the amyloid-related imaging abnormalities, or ARIA. I'm going to go through these in more extensive detail. ARIA is typically transient and asymptomatic and can resolve on its own, but sometimes can have serious consequences. So it's important for safety monitoring. All right, let's look at lecanemab. This is the Clarity AD study. What we see here on the left-hand side of the slide is that lecanemab significantly reduces the amyloid burden by PET. Okay, so there is a dramatic reduction in amyloid by PET. On the right side of the slide, we see that same change in the A-beta 42/40 ratio in CSF. So lecanemab hits its target and significantly alters the amyloid burden in the brain. This translates into clinical efficacy outcomes. So there are 4 panels here. One's looking at the clinical dementia rating score, sum of boxes. One's looking at activities daily living. One's looking at the ADAS-Cog, which is a cognitive test. And one's looking at a composite score of all of these different measures. And what you can see is in all cases, lecanemab shows significant slowing compared to placebo on all of its clinical efficacy outcomes. Let's switch to donanemab. In donanemab, the TRAILBLAZER-ALZ 2 study, again, we can see, looking at the changes in amyloid first, on the left-hand side of the slide, we can see the change in PET scan, a dramatic change. This basically clearing the amyloid from the brain. And you can see that those patients showed dramatic improvement in their amyloid PET scans, beginning at 24 weeks, and by 52 to 72 weeks, they're essentially cleared. Let's look at the clinical outcomes now. The way this slide is set up, on the left-hand part of the slide, we have the low to medium tau population. So everybody had tau scans, so we knew how much tau there was. And on the right-hand side of the slide was the combined tau population. And what you can see is for the primary outcome, which was a composite measure, the Integrated Alzheimer's Disease Rating Scale, the iAddress, that we saw a slowing with donanemab at 76 weeks for both the low, medium tau and the combined tau groups. And also in the other outcome, the clinical dementia rating sum of boxes, for both the low, medium tau as well as the combined tau. We saw dramatic clinical slowing. Now, what are these ARIA things that we're talking about? Well, these are changes on neuroimaging. They result from the amyloid in the cerebral vessels. So you're removing the amyloid from not only the brain, but from the vessels that feed the brain. And this can occur spontaneously as part of Alzheimer's disease, but is a little bit more noticeable when you're doing this by monoclonal antibodies. And there are two types. There's ARIA-E, which represents brain swelling. And you can see some examples on the left-hand side of the panel. These look at hyperintense signals on the MRI imaging. ARIA-H represents small bleeds, so microhemorrhages or superficial siderosis, and this is demonstrated on the right side of the panel. While most of these are asymptomatic, they can be serious and life-threatening, so it's important for the monitoring. Now, we have the advantage. There are appropriate use recommendation papers out for both lecanemab and donanemab, and I encourage you to read these papers fully. This slide is a summary of those two papers that tell you what the inclusion and exclusion recommendations are for treatment. It's important. You have to have a clinical diagnosis of MCI due to AD or mild AD dementia, and you have to demonstrate amyloid positivity, right now either by PET or by CSF. You have to have scores in the mild ranges of these impairments. APOE genotyping is recommended because people that have 1 or 2 copies of the APOE4 gene are at a higher risk for ARIA than non-carriers. And you must have a baseline MRI prior to starting medication. You're going to do monitoring as the recommended schedule is, and if you see either baseline MRIs with lots of microhemorrhages, if there's a contraindication, someone can't get an MRI, if they're on anticoagulation, have a bleeding disorder, an unstable condition, these may be exclusions for treating patients with these medications. Thank you for your attention. I am so delighted now to move on to the Module 2 and introduce my next speaker, Dr. Day, who's going to talk about applying these quality improvement measures to really close those gaps in the care of patients with Alzheimer's disease.
Hi, I'm Hollis Day, Associate Professor of Medicine at the Boston University Chobanian and Avedisian School of Medicine and Chief of Geriatrics at Boston Medical Center. And I'm here today to tell you about a quality improvement project that we did on trying to close gaps in care for patients with early Alzheimer's disease. Let me tell you first a little bit about our context, because that's very important for any QI project that you might want to do. Boston Medical Center is a nonprofit academic medical center and the largest safety net hospital in New England. We are a principal teaching hospital of the Boston University Chobanian and Avedisian School of Medicine. As you can see, we have a large number of outpatient visits and ED visits annually. But it's important to understand that in our context, 72% of our patients come from an underserved population. And of those patients, 32% have limited English proficiency. What we recognized with our older adult patients is that there was a significant practice gap in diagnosing dementia of any type or cognitive impairment, but specifically looking at Alzheimer's disease. We know that most of these diagnoses happen in the primary care setting. And when this opportunity is lost, our patients are often then too late for treatment options and the appropriate social support that they need for themselves and for their caregivers. We also understand that there are a number of root causes. From the physician side of things, clinicians do not always know which screener to choose and what to do next if the screen is positive. The screener that is chosen is often related to a patient's functional status, including their instrumental and basic activities of daily living, their education level, their preferred language, etc. We also know that in primary care, physicians do not have time to complete screeners with other competing priorities, especially when an interpreter is required. We know that there are a large number of systems barriers as well. We know that there are no currently established expectations for the frequency of screening, that patient access both to primary care and specialty, whether it's geriatrics or neurology, might be limited. And we also know that there are systems within the electronic health record that prohibit us from efficiently screening our patients. With our patient population in particular, there are a number of specific patient challenges. Not surprisingly, patients with cognitive impairments are much more likely to miss their appointments and therefore not have the follow-up that they need. We know that our patients who come from a different linguistic background, perhaps a lower education background, or even low health literacy, all struggle to both make their appointments and be able to follow up, particularly when they are starting to experience cognitive challenges. These same patients face multiple social determinants of health challenges, and interestingly enough, there's a large cultural difference in understanding of cognitive changes. Many of our patients come with the expectation that becoming cognitively impaired over time is just a normal part of aging, and that there's really nothing to be done about it. In order to address this gap, we tried some what I would call traditional methods. We gave grand rounds to our primary care providers. We did resident teaching conferences, thinking that from the ground up, we could encourage more people to screen our patients. We even had monthly drop-in case consultation sessions where people could bring their very challenging cognitive impairment patients and their cases to experts to discuss. So, knowing that these aspects of training didn't work, we decided to approach enhancing our screening as a QI project, and we entitled our project A Light on the Horizon, Improving Alzheimer's Screening and Diagnosis Through Quality Improvement. Unfortunately, our primary care colleagues saw that light as the light of an oncoming train. They were really worried that this was going to create a lot more work for them, and they weren't quite sure how they were going to handle it. We approached this as a QI project, looking at it as a why, who, what, where, when, and how. Now, if we look at this as a PDSA cycle, there are many benefits to doing a QI project. There's an efficient use of the data, collecting just enough to inform the best action forward. We can more easily refine our measures and data collection, and we can assure a high return on failure ratio. That is, we learn valuable lessons very early on with relatively little resources invested to learn those lessons. We could recognize the necessary refinements to the intervention that need to be made and identify the missing ingredients that therefore can make it successful. We increase the confidence that the change under consideration will produce improvement, and specifically by engaging the stakeholders in the development of the intervention, we were much more likely to minimize our resistance when the actual change was implemented. Now, as with any QI project, it's really important to understand what's the base rate of screening? How do you know this? And who's actually doing the data collection? This is particularly important to understand in your practice context. Now, when we talk about why we were doing this project, well, we really wanted to identify patients with dementia earlier in the disease process, as we know that this may allow for access to new therapeutics. And absolutely, no matter the stage of disease, we need to enhance the social support that patients and their caregivers are getting. This is definitely a health equity issue. The literature demonstrates that patients of color and other ethnic backgrounds often are diagnosed later in the course of the disease or not at all. We know that while the United States Preventive Service Task Force guidelines currently don't support screening, we anticipate that this is going to be changing soon. We also know that while therapeutics may have somewhat limited benefit currently, there's so many more that are in the pipeline, and we want our patients to be set up for success. Many of our physician colleagues said, I can't counsel patients on the risks or benefits of therapy, and that's okay. What you do need to know, though, is that the therapy exists. So we wanted to overcome some of these barriers, and by talking to our colleagues, anticipating some of the new guidelines that are coming out, and explaining to them that they don't need to be an expert on the therapeutics, but they do need to know the potential that a disease like this has on patients and their caregivers, and how to help that dyad really strengthen the meaning behind doing this project for our primary care partners. Now, in the United States, the Alzheimer's Disease Association puts out disease facts and figures annually. And what I want to highlight from the 2023 statistics is this. While only 4 in 10 Americans actually talk to their doctor right away when experiencing early memory or cognitive loss, 7 in 10 would want to know early if they have Alzheimer's disease, particularly if it could allow for earlier treatment. That's a huge gap that we're responsible for. So when we were thinking about this project, we had to decide, what patients are we going to be screening? All patients over the age of 65 or maybe 70? Only patients who actually have memory concerns? Or are there patients with certain diagnoses? For example, hypertension or diabetes, maybe patients who are missing their appointments or forgetting to take their medications. And these are decisions that within your practice you have to think about. Who is going to do the screening? Is this going to be a self-screen, as there are some options for this available? Will it be done by your medical assistants, nurses? Do you have a pharmacist in the practice that might be able to help? Advanced practice providers or physicians themselves more commonly doing this. What tools will you use? What tools are practical for a very busy primary care office? We have chosen the MoCA, the ClockDraw or the MiniCog, and the Rowland Universal Dementia Assessment Scale. We use that latter for our particularly for our patients who have lower education levels or limited English proficiency. Where do you do the screening in your practice? If it's a self-screener, you could do it in the waiting room. Do we do it in the triage room? Or do we wait until the patient is in the clinic room? When do we decide to do this? Is this just part of your standing agenda for a visit? Is it part of the Medicare annual wellness visit, which unfortunately does not work for all of our patients, particularly because a lot of them may not have Medicare? Or do you have a separate visit for cognitive screening? And how do you do this? It's very important to tailor this to your individual practice or clinic. You have to take into account your practice characteristics, what personnel you have available and who your champions are, and what are your technical needs. Can you put this into your EHR, or do you have to do it by paper, for example? Do you have champions? And these don't just have to be physicians or advanced practice providers. These can be nurses, these can be MAs, these can be many different people in your practice, but you need to have someone who really believes in this. Someone who can figure out the best timing for this, the roles and responsibilities of each member of the team in this project. And lastly, but most importantly, you need to have practice leadership buy-in. That's so important. At BMC, our partners were different depending on the department that we were working with. In family medicine, the practice partners were our physicians and our nurses. In general internal medicine, the practice partners were our physicians and our pharmacy colleagues. So it's really important to identify your partners in your practice. So what are some key takeaways as a dementia specialist for this particular QI project? Well, first of all, the reason we do any QI project is to improve patient care. Here, what we have been able to do is to set up an infrastructure to improve the screening, the diagnosis, and the referral rate of individuals with early Alzheimer's disease or other dementias as a necessary prerequisite. This enables our patients to access new therapeutics now and down the line as they improve, and most importantly, to help patients and their caregivers access the resources that they really need. What's some advice if you're trying to set up a similar type of project? Well, first of all, partner very early with your primary care partners to establish a clear referral pathway and protocols. It's important to designate clinical champions, including interprofessional colleagues from each clinic or department, to drive the buy-in, the education, and the workflow change that enables a project to be successful. We have had to embed screening tools into routine clinical workflows. This is critical. You don't want to make extra work as part of this process. We've used digital tools and transitioned from paper-based cognitive screeners to flow sheets in Epic or an equivalent EHR. Most importantly, as part of any QI project, we need to track performance metrics and provide feedback to enhance the progress that we've made, but also to identify the gaps where they might be. We have to iterate and scale. We use these early successes to pilot refinements, gain leadership buy-in, and scale improvements across additional departments or clinics. Taking these steps together, you can have a highly successful project.
Hi, my name is Heather Ross. I am a family medicine physician at Boston University and Boston Medical Center. I was excited to join this QI project as I often find cognitive screening tricky to fit into a busy primary care clinic, so I was excited to look at the barriers and address those with a QI lens. We first looked at different barriers in our clinic, first looking at patient factors. Patients often have multiple concerns that they want to address at a visit. Memory might be one of many of their concerns, or maybe is not a concern that they want to address. I also have noted some cultural barriers when doing some of the screenings. For example, some patients might not be able to name some of the animals that are needed on the MOCA or similar things to that. And then some patients might think that this is normal aging, losing their memory, so they might not bring it up to their physician or maybe don't think it's something they want to talk about. In terms of provider barriers, first, clinicians might not be aware where the screeners can be found in the medical record, or that they are available in the medical record. Secondly, there are multiple screeners that we use, including the RUDAS, the MOCA, the MiniMental, the MiniCog, so providers might not know what screener to use for what patient. And then additionally, when you're thinking of when it's time to refer, asking who to refer and at what time in the disease process. We also thought of kind of systematic barriers. First, in our clinic, our provider visits are 20 minutes, so limited time to do a screener for cognition. We also generally have poor access, like many primary care clinics. It can sometimes take a few minutes for a patient to get in to see their provider. And then providers are the only ones who are doing the screeners in the clinic. No one else was trained to do the screeners. Additionally, our clinic doesn't have the annual wellness visit, which many clinics is where you will do the cognitive screen. So I think overall, the biggest barrier is time in the clinic setting. First, you need to be able to choose the correct screener. If you want to do a cognitive screen, you need to find the screener online or in the medical record. Prior to this project, I was searching online on Google and printing out the screeners. You need to administer the screener. This can take anywhere from 5 to 10 minutes, sometimes longer if a patient is struggling with the instructions or needs to use an interpreter. You then need to document the screeners and doing all of that in 20 minutes while addressing the other concerns a patient or a provider might have. So we did multiple interventions throughout this project. I broke it down into a few buckets. First, we targeted and thought of provider education. We did that in a number of ways. First, we did a grand rounds for the family medicine doctors in our clinic, led by the geriatricians, especially as our kind of family medicine guidelines that we follow, the USPTF recommends against routine screening. So the geriatricians came in, talked kind of why screening is important, some of the screeners that we use, some of the new treatments for dementia that are on the horizon and how to choose what screener. And then we also added some education on where to find the screeners in the medical record. The next ones I'll go into more on the following slides, but we made some changes to the medical record itself, and then also worked to improve access by developing a nurse-run geriatric assessment clinic. This is our main data that we've obtained during this QI project. To orient you, this shows the percent of patients every month who have undergone cognitive screening with the flow sheets in our clinic. Our project started around March 2024, so is the third bullet to the left. So you'll see our baseline screening prior to this project was about 1% and has been kind of gradually increasing over this project time. This next slide just goes into kind of when we've added the interventions in this time. So you'll see we kind of gradually added them throughout this QI project, starting with the grand rounds, adding in the nurse training and nurse screening, and then adding in some medical health record changes throughout. So in terms of interventions, we gave some education on where to find these screeners in the electronic health record. Prior to this project, I didn't realize they were available in the health record and would often search for them online and then free text them into our medical record. Of note, we use Epic, so any screenshots you see will be from our Epic medical record. So we did two things. I gave some education by a talk to the providers on where to find the screeners, and then also gave a handout with the screeners. So on this slide, you see that the screeners, the RUDAS, the MoCA, the mini mental status are available in flow sheets, and you can see the instructions and then give the score for the patients. Additionally, if you're in a patient visit, in our assessment and plan section, you can find the screeners. You see next to the one in the green, you see the mini mental, the RUDAS, and the MoCA. Next, moving on to changes in the health record itself. First, we made a cognition resource folder. Prior to this, there were no PDF versions of the cognition screenings in Epic. You would need to search for them and then print them out if needed. A lot of times it is easier to have a printed version, as a patient might need to make a clock or draw some lines to connect, so it's useful to have that printed version. So we have the PDFs all in one place. In addition, we added other cognition resources. Our hospital has a connection with the Alzheimer's Association. It's a way for us to refer patients who have any type of dementia or their caregivers for additional resources or additional supports if needed. Other changes we made was helping streamline the referral process. In our hospital system, there's two ways to refer to a memory specialist. One is to the geriatric memory clinic, and one is to the neurology memory clinic. A lot of times prior to this, there are certain criteria on who to refer to what clinic, and you'd have questions on where to send someone. So we kind of streamlined that process, said who is eligible to what clinic in one place. And then sort of the last change we made was add a healthcare maintenance flag. If you use Epic or if you're familiar with it, there is a care gap section, which you see in that left topmost screenshot. This includes different types of health maintenance that a patient might need, such as vaccines, different types of screenings, such as cancer screenings, behavioral health screening. So we added our cognition screening here. This will pop up for any patient who's over the age of 65 to discuss if cognitive screening is needed. There are a couple ways that we were able to close this care gap for a patient. One is if you do one of the cognition screens, it will automatically close it. Or if you feel or the patient feels they don't need the screening, you can just close the gap as you see in the picture on the most right. And then it will pop up again in the next year to remind you. And then the last intervention we did was start a nurse-run geriatric assessment clinic. I think this has been one of the biggest benefits we've seen. Early on, we realized providers just don't have the time or the access to do the amount of screenings that are needed. So we sort of looked through who else who is in the clinic and who can do the screenings. Our nurses were looking for more patient-facing care, and we're already doing a hypertension clinic, so we're excited to partner with us and do this. We worked with our geriatric colleagues to create kind of a comprehensive assessment similar to what the geriatric nurses do in their clinic. This assessment would cover the cognition screening, but then also kind of look more at the patient as a whole. So ask questions about their living situation, their social supports, how they're doing with their ADLs and IADLs, if they have a VNA, if they should have a VNA, if they need a day program, if they need any medical equipment, kind of really thinking of the patient as a whole. Nurses would see the patients by provider referral. So example, I would see a patient, want them to get screened cognitively, and then set up an appointment for them to come back and meet with the nurse. Prior to this clinic being set up, the nurses received training on all of the screeners. They both learned how to administer the screeners and how to score the screeners, and then were able to practice that. And additionally, they were taught on how to choose what screener for what patient. So for example, we decided the RUDAS is best used if someone has limited English proficiency or if there's a level of education under high school, versus the MOCA if they are predominantly English speaking or if they have a high school level of education or higher. Those are kind of the two most common screeners we use in our clinic. And then after that, the visits are sent back to the provider to follow up. We also looked at some other measurements in addition to the number of flow sheets per month. We also looked at who is doing the flow sheets. About half or more of the screenings are done by the nurses each month. You'll see kind of other things we measured along. If the screeners were documented outside of the flow sheets, how many patients were being referred to see a specialist, how many patients were being referred to the Alzheimer's Association, how many patients, if they screen is abnormal, have a diagnosis of dementia in the medical record, and then kind of how the access is to the specialty appointments in terms of weeks to months once the referral is put in. I think there have been a lot of benefits to our QI project. First, in terms of the nurse assessments, they have the ability to do longer visits than us providers. They're able to do up to 1 hour visits compared to 20 minutes, and they have much better access than the providers. If I was seeing a patient, they would sometimes not be able to see me again for a few months, and then might forget the appointment or have more urgent things that need to come up. Nurses sometimes can do same day versus sometimes later that week, so can get in much sooner. And then with the changes to the medical record, kind of having all the PDFs in one place and some of the other changes we've made helps streamline the process, reduce the time it takes in a visit, and then puts kind of the screening front of mind in the clinicians. Overall, this has been greatly beneficial to patient care. Our numbers started around 1%, and now we're screening close to 7% of patients per month. This leads to faster screening, which helps kind of improve next steps in terms of treatment, referrals, and any other testing that is needed. We did face some challenges with this project. First, in terms of the USPTF guidelines that recommends against routine screening, we address this by providing some education through the grand rounds and the benefits of screening, and likely the fact that we're missing some patients. We encountered some tech barriers along the way and took some time to obtain approval to get the screeners into Epic. Sometimes would take months at a time. And then the time barriers persist in family medicine, but with the help of nursing colleagues, that has reduced. And then lastly, I think why it's been successful in our clinic has been for a few reasons. One, our family medicine clinic is a smaller clinic compared to some of the other primary care clinics at our hospital. And we're the only family medicine clinic attached directly to the hospital. So we're used to kind of piloting new processes and used to kind of change along the way. If you're thinking of implementing something like this in your clinic, I would first think kind of broadly and systematically of the barriers in your system. Use the medical home to your advantage. So we used our nursing colleagues, but you could also think of if a pharmacist could help out, if a medical assistant, et cetera. And then using those PDSA cycles to help kind of make gradual changes as time goes on. Thank you for your time, and thank you for joining us today.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by Boston University. This activity is developed in collaboration with our educational partner, PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/PEW860.